Yeah, thank you for that, Simon. It was an excellent introduction. Thank you very much. So, yeah, as Simon says, I'm John Utley. I'm the Programme Director for Hereford and Worcestershire Integrated Care and Wellbeing Record. And today I'm going to talk to you mostly about the patient portal and shared care plan solution. And as Simon says, we've already involved Healthwatch in this programme, but we're now at the point at which we would like to invite particular patients and citizens to get involved with us. Because the patient portal that we are procuring, we're actually in a position where we're going to be building out the functionality. So it's important that we get involvement early on from patients in how we take that forward. So can I ask you to move on to the next slide, please? Thank you. Okay, so what we've got here is the capabilities that we anticipate that the patient portal will give to citizens and patients across Herefordshire and Worcestershire. So if I start on the left-hand side, we've got video conferencing in a one-to-one and one-to-many. Now, as was said earlier on, Zoom and video conferencing has come a long way in a very short period of time due to coronavirus, and just a few short months ago, the NHS didn't really adopt video conferencing, certainly in the way that it has today. So one of the important capabilities we expect to be within the patient portal is video conferencing, both on a one-to-one, as in between you and a clinician, but also one-to-many, so where, for example, a clinician may be running an educational or awareness programme on how to live with a particular condition. Then we are looking at how we can centralise electronic letters and communications to patients. So as an example, Wolverhampton Acute Trust currently spends about £1.2 million a year on postage costs. We would like to see how we might be able to reduce that within Herefordshire and Worcestershire, both from a perspective of your GPs sending out letters, but also the various hospitals and social care. The way we see that operating, though, is that patients would be asked to opt in. So it's a bit like the way it works with your bank, where the bank encourages you to go paperless. Then moving on, we've got appointments. So the ability to book an appointment within your GP practice, but also to rebook any outpatient appointment within a provider setting or a hospital setting. Then moving on, we've got shared care plans. So this is one of the probably the most important areas of the patient portal. So what we want to see is a shared care plan that multiple agencies can have input into, as well as the patient and potentially any carers. That's really important for us because at the moment that functionality doesn't exist. So multiple agencies have different views on what's happening with the patient. And what we really want to do is bring that together into a single instance that everyone's clear what the plan is for that patient. The portal will also give the ability for patients to set their sharing preferences. And the importance of this is twofold. So one is which other person do you want to be able to access the record in the patient portal? So it might be family, it might be carers, and so on. The second aspect of that is what information. So at the very bottom of the screen, you can see we've got primary care, hospices, social care, WMAS is the ambulance service, and then provider trusts. What you will be able to do is set out what your preferences for sharing your record with those various different organisations. So for example, if you've got a mental health record but you don't want it shared, then you would be able to, in effect, keep that secret. The friends and family test and built-in surveys. So the NHS and social care will be able to run various surveys through the portal so we can gain insight into the care that you're receiving and also the services that we are providing. Patients will be able to record data into the application. So, for example, if you're being treated for depression, then you might be keeping a mood diary, or if you're on an NHS prescribed diet, then you might be keeping a diary and so on. But equally, you might have various devices at home which you might want to record the data that comes out of those, so things like Fitbits or blood pressure devices and so on. A strong request came out of various groups around the ability to have secure messaging between patients and clinicians. So rather than needing to pick up the phone, you can have a secure messaging capability. And then moving on, we've got repeat medications and medication reminders. So this is the ability for you to ask for repeat medications. So you can currently do that through your GP practice, but you'll have the ability to do it here within the portal as well. Then we're going to offer you advice and guidance so that you can better live with the conditions that you have, and you'll see some screenshots in a few moments of what that might look like. Telehealth and telecare is another important programme of work that's currently happening within the STP. So we are looking at how we might be able to use technology which does things like remote diagnostics. So for example, if you're a patient with COPD, which is a respiratory condition, what we'll be able to do is to understand what the blood oxygen level looks like for you as an individual. We know what the normal reading looks like for most people, but for you as an individual, it will undoubtedly be lower. And what we'd be able to do is, using that remote diagnostic information, we'd be able to see your O2 levels going down, and then we'd be able to use community staff to intervene, because typically what would happen is you would go into what's called an exacerbation that would then lead to a hospital admission. Using this kind of remote diagnostic data would help us to intervene much earlier and stop you being admitted into hospital. Then finally, again, we have, again, through the STP, a recommended app store. So we would personalise that to you as an individual. So if you have diabetes, for example, then we would recommend various diabetes apps to you to, again, help you better manage your own condition. The other thing you would be able to do then is look at your own health record. So underneath you can see that we've got primary care, hospices, social care, WMAS and provider trusts. So you would be able to see your information that's currently held about you in those different organisations. And similarly, the clinicians who are at the bottom of the screen, they would be able to see everything from each of those different organisations. And I should say that that's not currently the case. So GPs routinely do not see information, for example, from social care or know what's going on within hospices and so on. Although actually that's changed quite significantly over the past few years with things like Black Pair. So the GPs would access what's called the integrated care record, and they would access it through their core clinical application. So if you're a GP, then you currently use EMIS, and you would get to see all of that information about that patient within EMIS. So we're not asking clinicians to log into other applications. So that's the core capability of what we're trying to put in place. If we could move on to the next slide, please. So these are just a few example screenshots of similar solutions of what we're looking for. So in the top left-hand side, this is just an indication of what you would see as a patient around your own health. So you can see that we would be showing you things like your diagnoses, your medication, allergies, and so on. In the top right-hand corner, you've got the ability to see all of your upcoming appointments. Now, the 2 appointments that are showing there are just for the hospital, but actually you would get to see all of your appointments. So any GP appointments you've booked, any outpatient appointments within an acute trust or within the health and care trust and so on. In the bottom left-hand side, you've got the ability to add people. So that on this particular site, it's called Circle Friends. So you could add in members of the family or carers, and they would be able to access your record and potentially advocate on your behalf. And then on the right-hand side, you've got some typical type analytics that you'll be able to run. Okay, if we can move on to the next slide, please. Okay, so there's some duplication here. So if I start in the bottom right-hand corner, again, that's your kind of friends and family, so who can access the system or your record. and you can see there that you've got the ability to specify what they can do, so which bit of the record they can access, so you don't have to give them access to everything. In the top right hand corner, you've got the help and guidance. So in this instance, a video that's been recorded by Worcestershire Acute, the cancer services, and that particular video is talking you through kind of what to expect from the service. But you'll also have videos on how to better manage your care and so on. On the left-hand side, you've got what a care plan would look like for you as an individual, and this is probably one of the most important aspects of what we're trying to deliver. So in this instance, what we would ask is that the patient give us some kind of key information around what their aspirations are. So if I was to take myself as an example, I'm a patient with asthma, but I'm also overweight, so I need to lose 5 stone. Now, I've had that problem for a long time, and I've done nothing about it, but now I'm thinking about my retirement. I want to ensure that my retirement years are spent in good health, and so I'm now thinking about what I need to do to lose that weight. I think it's typically the case, isn't it, that we would do, if something was going to impact us quickly, like COVID, then you act quickly. But for things that kill you slowly, you typically don't do a great deal. So for me, that's a personal goal, is to lose weight, and that's where you would kind of record some of those things that are important to you. So that might be walking your daughter down the aisle and so on. If we could move on to the next slide, please. Okay, so what are the benefits then of this programme? So clearly, the important one for us is patient and carer experience. So just the very simple example. Typically, as a patient, you get asked the same questions time and time again. When the clinicians and professionals involved in your care have got access to the information that they will have through the integrated care record, then you won't need to repeat yourself quite so much. And that should give you a better experience. But there are many more examples than just having to repeat yourself. So the ability, for example, for us to remotely monitor your condition and intervene at an earlier point, which stops you then being admitted into hospital, again, will just give you a much better experience. Personalised care, again, if I think about some of the remote diagnostics examples I've given you already around COPD, for example, or the fact that you would have a care plan that's dedicated to you and is built around your individual needs, and that all of the teams involved in your care are aware of that plan, then that would give you much more personalised care experience. Improve safety and reduce costs. So when I used to work in an acute trust a few years back, if a patient was admitted, they would typically come into hospital with a bag full of medication. And the reason they did that was because the hospital doctors didn't know what was being prescribed within primary care. So the patients would turn up with a bag of medication. And that's really important, because actually if the acute clinicians don't know what medications you're on, then there's a potential for what's called contraindication, which means they prescribe you something which will react against the medications you're already on and could make you significantly ill. So if we can remove those medication errors, then that's both an improvement in safety, but it's also, again, a better patient experience. And in terms of reduced costs, if we can reduce those medication errors, then you won't be in hospital for as long, and therefore you'll have a reduced length of stay, and that means your care costs will be reduced. But there's multiple other examples we can give other than just medication errors. Avoiding a hospital admission. Hospitals have always been a fairly dangerous place with things like MRSA and C. diff infections. But now we're in the world of coronavirus, that's even more the case. So we absolutely want to avoid patients going into hospital wherever it's appropriate to do so, and treat patients either at home or within the community. Improved engagement in care and wellbeing. So again, the very fact you would have your own care plan that you would be encouraged to get involved with. I mean, it's not mandatory. You could sit passively and let the clinicians make the decisions for you, but obviously we would encourage you to get involved and advocate on your own behalf, or at least carers having input into your care. Support safeguarding, again, it's fairly simple, and that's both for the patient and for our staff. So, for example, if there's a note in any one of the partner organisations, for example, that you've got a dangerous dog at your address, then if any other member of the community goes out to our address, then they would get to see that kind of intelligence. And then better population health intelligence. So again, I've been in the NHS for 23 years, and there hasn't been a single year that we haven't gone through some form of significant change. What we would have by pooling all of this rich data together, we would have access to an anonymised data set, which would tell us how those services that we're currently running are performing, but also if we're doing any service transformation, and as I've just said, we're always doing service transformation, then what that would enable us to do is to model the impact of what we're proposing. And that's simply, I mean, we do that to an extent at the moment, but with the rich information we'll have by pulling all of that record together at a population level in an anonymised format, that will be a massive boon for the STP to be able to understand what those service transformations will deliver. And then finally, we anticipate a minimum of £8.3 million saving, and that's against a cost of £3.3 million. Now, that 8.3 million is I think is the low end. I think we'll get far more than that. But just as an example, I mentioned earlier on that the Wolverhampton Acute Trust spends, I think it's £1.2 million on postage. If we were to look at what Worcestershire Acute and Wye Valley Trust are doing, we'd probably come in around the same ballpark figure. So on postage alone, we can save a significant amount of money. Next slide, please. Okay, so in terms of timescales, then we're going out to procurement for both elements. So we've got the integrated care record infrastructure, which is the back end of the system. We're going out to procurement for that this month. And we're also going out to procure a development partner to build the patient portal and shared care plan solution. That means that in October and November, we'll be into what's called a discovery phase, and that's where we literally we start to map out all of the different systems that each partner organisation has got within the STP and look at how we're going to join all of those different systems together. By March of next year, we will have implemented the back-end infrastructure. That's how we pull the various clinical systems and social care systems together. And we will also have launched the first element of the patient portal. It is important to note that we are developing the patient portal, so we will probably be in the development phase for at least three years as we build out some of that capability that I referenced earlier on. And then population health management will be ready, we anticipate around June or July of next year. And I think that's the end of the presentation.
John, thank you very much. How would you want to take questions and queries or comments from the people watching and partaking today? Should we just take them as they come?
Yes, please.
And I mean, that was very good in kind of quarter of an hour, a bit of a wow factor from me. And so shall we have, 10 minutes, quarter of an hour of questions and comments?
Yes, please.
And again, if anybody wanted to follow up a more detailed query from you, can they contact you?
Yes, absolutely. I'll send around my email address and my mobile number.
Oh, that'll be very helpful. Thank you. So Pip, if you want to indicate when you'd like to speak, I've got my little list here and I will bring you in that particular order. Obviously, for John's purposes, would you let him know who you are? Because obviously we've only got him on sound and things. So Jane, your hand was up first.
Yes, thank you, John, for a very, very interesting presentation. I have one of my responsibilities, end-of-life care, and also I'm very interested in the respect forms. And I just wondered on the patient portal where the respect data will be recorded and how that will actually take place. Thank you.
Thank you. Okay, so one of the elements of the patient portal that we're already working on is the end of life care plan. So we've got the likes of Julia Neal, Maggie Keeble, Roy Williams involved in that aspect. So we're just at the point now which we're forming what's called a design cell. And that design cell is going to help us to build out the requirements of what the end of life element needs to have. And that then will form part of the developments that we do with the patient portal. So we're at the early stage, but respect, end of life is a priority for the STP. So that work is beginning now. And again, if that's an area you would like to get involved with, then you're more than welcome to join the design cell, because we are looking at how we can get representation from organisations and from patients, because it's important that we engage them in the development of this solution.
Lovely, thank you. I would be interested, thank you.
Caroline, yes, please. Again, would you let John know who you are, because obviously he's only on sound.
Yeah, hi, I'm Caroline Carver. I'm just an ordinary member of the public. I live in Malvern. It all sounds absolutely wonderful, but as a retired teacher and having dealt with things like records of achievement that were absolutely wonderful, but nobody ever had time to read them, are GPs actually going to have time to really look at this and digest it and work with it? Because in my experience, even when things are recorded, they don't always get back to GPs, and GPs just don't have the time to look at them. I'm not getting at GPs, but it just aren't available.
Oh, good point, Caroline.
Yeah, absolutely. So the way we see this working for GPs in particular is that the integrated care record would be available through EMIS. So you're absolutely right, they are very busy people. But if you're a GP, you've got your EMIS solution open at that point in time. Potentially you've got a patient record open. What you would see in the top right-hand corner would be a new tab for the integrated care record. They would select that tab, and basically your record would then populate for every other organisation that we know or is involved in this programme. What we will do with the GPs is we will work with them to understand what elements of the screen they want to see. So we won't deluge them with everything we know about this patient. What we'll do is we'll prioritise the elements that they think are important that they need to see, and that way it will streamline them and enable them to prioritise the view. So then if they wish to, they can then click through to see what information is within the patient portal. So if you're keeping a diary, for example, then they could take a look at that. But again, it comes down to the timescales that they've got available to them.
Next question, Chris. You need to come off the mute, Chris.
Yep. Hi everyone. I'm Chris Byrne, Swallows lead for Head and Neck Cancer Charity. So on the cancer charities out there, how do you see organisations like ours getting involved in this?
Yeah, so two ways. So first of all is to, again, help to take part in the design cell so that we can take account of your requirements. And again, that's an open invitation to anyone to help to work with us to build this capability. But also, I mentioned earlier on when we looked at the functionality of what we anticipate for the portal to have, there's that element of sharing preferences. So if you're involved with a patient as a charity, then that patient could grant you access to their record. And that way you can help to then contribute to the information that's generated about that patient, including potentially having input into things like the shared care plan.
Perfect, thank you. And second and final question is this being designed by Hereford and Worcester, or is it being rolled out elsewhere across the country?
So, so the scope of this programme is just Herefordshire and Worcestershire. However, the organisation that we are almost certain to go with has already developed similar solutions in other parts of the country. So they're currently working on the patient portal for Cheshire. They have a portal down in North London and so on. So they've got other examples around the country.
Yeah, because I was just thinking about, in terms of when you roll this out, you'll be able to share ideas with other organisations. I presume that's all part of it.
It is, absolutely. And one of the really important aspects we've considered for this is that the organisation we want to work with, the way they charge is that if they've built a function for another part of the NHS in a different part of the country, they won't charge us again for deploying that into our instance. So it just helps us to keep the cost down, not just for us actually, but for other parts of England and the NHS.
Thank you very much. Thank you.
You're welcome.
Questions from anybody else? Joe.
Hi, yes. I have a question around digital access and what you will be doing as part of the project to take account of people who don't have access, whether because they have poor broadband or they can't afford the kit or the data, or they have sensory impairments or whatever like that. What sort of backup there will be for people who don't have access?
Yes. So again, that's another work stream for the digitally excluded. So as an example, I was on a call earlier on in the week around another topic for community diagnostic hubs. And we proposed there that one of the elements of setting up these community diagnostic hubs could be that patients could if they were digitally excluded, could use those hubs to go in and make use of equipment within there to access some of this digital material. Also, we anticipate things like libraries and so on. But again, it's slightly difficult in the world of coronavirus because, of course, we want to ensure social distancing and so on. Yeah. But it's one of the key strands of the programme is we're looking at how we can include people who are digitally excluded.
Yeah, also because that brings into account sort of privacy and data control and access and security and all that sort of stuff as well.
It does.
Thanks.
Yeah.
Jonathan Sutton.
John, I'm involved in the world of the single homeless, which you will recognise as inhabiting the nexus of many health and social inequalities. I just offer an opportunity for your team to come and see ourselves, and we can coordinate with the other homeless charities, because I think there are some particular challenges that this brings for those groups we look after, particularly in terms of digital exclusion. So please do that, because this is a real opportunity to join things up. The second is just a question of interoperability, and it picks up on Chris's point earlier. What we know from mapping the homeless person's journey is that there is a number of sequential referrals in their journey between housing and health and the various parts of health. And I just wonder whether at the boxes at the bottom, and you explain the capability map, whether housing is going to be included in that, because I would imagine if you were a housing officer in a local authority trying to put a housing support plan together for a person and they were able to give you access to those records, that would be quite useful.
Oh, yes.
Yeah, I agree entirely. So first of all, yes, I'd like to take you up on the offer to come and talk to you. In terms of housing, so at this point in time, it's not part of the scope of the programme. However, that's not to say that it couldn't be. And previous conversations I've had with Simon, for example, he's pointed out that domiciliary care should have access to this integrated care record, and we're already anticipating that care homes will get access. So we're not against enabling housing to have access to the record, but we're not there yet. It's you're the first person that's raised it as an issue. So, but if that's an important element, then absolutely we can raise it as part of the programme and look at how we build that into the roadmap.
I just thank you. That's really helpful. Just if you may not know that Worcestershire has a strategic housing partnership, which is the collaborative organisation committee, and the chief executive of Bromsgrove and Redditch, a good chap called Kevin Dix, is the chair of that. And I'd perhaps suggest go to Kevin first, because it's that group where health, social care, housing come together. So I guess that would be the place to go and ask. It's well above my paycheck, John, but Kevin is the man.
Yeah, thank you.
Peter, can I just come in on that point?
Yes, Simon.
About access. John, one of the things we haven't spoken about is whether schools would have access to this, particularly for looked after children. You could see particular cohorts of children where they might want access to it.
People referral units with health and care plans. Yeah.
Yeah. So we can note that one down. I'll raise it on Monday morning.
Yep. Okay. Thank you.
Meeting.
Yeah.
Anyone else? John, I wanted to ask a couple of questions. I'm a long-term condition a patient, so I'm involved in the NHS personally because I'm interested in what's going on with my condition. So I'm part of the NHS app, and I've access to my records, and I liaise with all the people. Will the portal link all that together? Will the people that I currently, share and have contact with be aware of my current, long-term condition links and everything else with my diabetes and my heart and things like that?
Yes, absolutely. So one of the things I didn't say was that, again, if you think about the functionality slide that I showed, when I talked about the ability to book appointments and to ask for repeat medications, you can actually do that at the moment through the NHS app. Now, what we anticipate doing is linking the portal into the NHS app, so that you've got one and the same functionality. Also to the point of using the NHS login as well. So if you've gone to the extent of using the NHS app, then you've got an NHS login. So we don't want you to have multiple logins. We want you to use the same one. What that then gives you is a view of your record and all of the people who are involved in your care, such that if, for example, an ambulance crew came to your address, they would be able to see which other professionals are involved in your care and potentially give one of those a call, as opposed to just dropping you in the ambulance and taking you into hospital.
Yeah, I've experienced that with my individual number, John, and it's worked reasonably well, quite honestly. I just want to make sure that when you do your portal, which is very, very interesting from my perspective, the things are linked up.
They will be, absolutely.
I just wanted to ask also a technical question. What, as a member of the public and a patient, what kind of equipment do I need to partake in the portal? So
any smart device. So basically, as long as it's got some form of connectivity, it could be a smart TV, it could be your phone, it could be a tablet, it could be anything. So as long as either the patient or a family member has got that, then you should be able to access everything that you need.
Thank you very much. John Taylor. You're muted. Well done, John.
Sorry, I couldn't get it off then. John Taylor from Healthwatch. I just wanted to ask about the privacy issues, because it seems to me that presumably people can give access to other organisations or people for a limited period of time and then stop that. Is that part of the way it works?
It is. So at the moment, what we've said is that the patients can grant access to other individuals, whether that's care or family, but also to grant access to particular parts of their record to clinicians. So I mentioned earlier on that you might be able to grant access to everything apart from, say, your mental health record.
Right.
At this point in time, you would grant access. What we haven't yet had a conversation around is how long that consent should last for. So it is a good idea, actually, that the patient should be told, I don't know, every 6 months, 12 months or whatever, that those consents still exist, and maybe give them the opportunity to review it.
Right, thank you. And a couple of other questions. One is around access within care homes, for instance, and how that will be controlled, and how they may be given training to use the system properly, because there will be issues of privacy in that setting, I would guess.
Yeah. Yeah. So, and again, this is a conversation that myself and Simon have had. So there's two potential ways that care homes could get access to the system. One is where the patient grants them access themselves, so they can then see the record and contribute to it. And that's obviously with the full consent of the patient. Or the second way of doing it is the back-end solution, which is the interoperability piece, the integrated care record. That comes with something called clinical viewer. And the care home could be given access to the clinical viewer, which they could then contribute to in terms of adding to the patient record. In terms of privacy for there, everything that gets done both within the patient portal in terms of access and any changes made, and also within the integrated care record, everything has a log created, and therefore we've got an audit trail of who's accessed what at what point in time and what they did. Yeah.
Oh, that's helpful, thank you. And last question for me, what about people with mental capacity issues? People with dementia, how will the system work for them?
So I would imagine that for those, it would be more a case of the carer having access. I have to say I'm not that familiar with the consent issues around dementia patients or mental health patients, yeah. So in all honesty, I'm not that 100%. What we would need is there's already a mental health work stream that's ongoing that David Brown, the CIO from Worcestershire Health and Care Trust, is involved with, as well as clinicians within the trust. And it's something I can raise with them as an issue, but unfortunately I don't have an answer really.
No, that's fine, thank you.
You're welcome.
Thanks everybody, and thank you, John. John, just final one from me. What would you want in terms of ongoing involvement and access from Healthwatch? I'm sure Simon and the team would be very keen to help shape what's going on, but have you any thoughts on that?
Yeah, definitely. So Simon's already part of the programme board, and we meet every 2 weeks. So Simon's already given us input around that. But the other element is two things. One is involvement in the programme. So we've got these design cells which are helping to build the functionality of the patient portal, and we would really like input from Healthwatch and patient groups and charities to help design what that looks like. And then the other aspect, I guess, would be for me to come back and give you regular updates on
that would be helpful.
Yes,
that would be very helpful. And also your indication of your contact should any of the public non-executives, that partake in this would want to just a query. That's a very helpful access, John.
Yeah, I've put it onto the chat, so that's my email and my mobile number.
David, you were indicating, Dave Saunders?
Yeah, just as a final thing there, John, what about people, I know one particularly with severe visual impairment who live on their own? Is there any way of getting to these people who are unlikely to be able to pick up the normal sort of interactive issues with IT?
Again, so in terms of the group we've got established for digitally excluded, there's also a separate group around those that have other challenges in terms of accessing the technology. So we are looking at how we can build the solution so that it includes things like readers and so on. So you can see the page would actually read to you the content of the page and give you the ability to interact with it through voice. But that's probably something further on down the line. What we want to do first is get a portal out that can solve issues for the majority of the patients, and then over the next 2 to 3 years we look at how we can improve functionality for all patient groups.
Yeah, it was just a simple issue of getting that person to know that the portal exists at all.
Yeah. Yeah, good point. So we're doing lots at the moment around comms and engagement and how we raise the profile, and that is why I'm here today, to raise the profile with yourselves. GP practices will have information leaflets and so on. We're going to be talking about how we get access to things like radio stations and so on to promote the message. So we're considering at the moment whether we whether we write to every single household across Herefordshire and Worcestershire again to let you know of the programme. But again, that doesn't, well, we can have in things like large print and so on, but we will be involving various groups to help us design content for that.
Thank you. Thank you.
You're welcome.
I'd got Pete Sugg indicated.
Yeah, there's two areas of interest of mine. One around the visual impairment. To be really good in terms of what you said there, John, about using support groups, but also making sure that all the technology actually has been tested with lived experience, because there's a major issue around readers not actually being as usable for systems as the technology says they are. So I really think there needs to be a lot of road testing. And then going back to an earlier point from Simon about the schools' interest, obviously there's a bit about looked after, but I think around the health and care plans bit that Jonathan raised, I think that's really important in terms of special schools, because health and care plans are very sort of mysterious. So being able to do something that is more helpful would really help. But again, it needs a lot of hands-on support.
Yeah. And again,
I just mentioned that point, John. I mean, I'll mention it on Monday morning, but SEND, I'm thinking of people with a SEND plan.
Yeah,
in
absolutely.
particular. Yeah, should be involved in that, because they normally would have a care plan as well.
Exactly, because I think the looked after bit would be maybe dealt with elsewhere because they have a lot more support. But actually, in terms of the SEND, especially vulnerable parents and stuff, or parents under stress and things, that can easily get lost. But via the schools, you've got more chance of support.
Peter, just before John goes, John, can I just raise an issue that I know I'm pushing you at every meeting on, and that is actually making sure that we do actually have the opportunity to talk to patients, etc., about what the interface looks like, what the portal will actually look like to them when they use it.
Absolutely.
And just make sure that there is time built into the plan, because I think we would rather it was delivered perhaps a little later, but was something that people could use, because we have a lot of, shall I say, older people who can use technology if it's intuitive.
Yeah.
But they can't use it if it's not intuitive. So I know that's a point I make regularly to you. And the other thing is, for some of us, you could forgive us for being slightly cynical, because most of us on this call today have been round the block before with this, under the Well Connected programme. But you haven't mentioned the big difference here is the commitment to fund it, which didn't exist under the Well Connected programme.
Yeah, absolutely.
So just to deal with any of that cynicism, I think it is worth you mentioning that there is a commitment to fund this.
Absolutely. So, and in terms of that financial commitment, it's basically the CCG has agreed to fund the programme, including the programme costs. So, and that's made the entire programme significantly easier, because we're not asking any of the providers or social care organisations to put their hands in the pockets. So the CCG is funding the entire programme. The only thing providers and social care need to do is ensure that they engage with the programme in terms of providing the technical staff and the project staff to deliver the programme within their organisations.
Pete Young,
Just my final bit was going to be, following on from Simon's point, was about the great role Healthwatch can play as a critical friend in terms of actually asking the questions as to whether or not the programme is working, particularly for those various vulnerable groups we've just spoken about, isolated groups.
Absolutely, and that's why we've invited both Healthwatchers onto the programme board.
Brilliant.
And we would like your participation in the design cells as well. So not just Healthwatch itself, but actually some patients. Just picking up on Simon's point.
Yeah.
We don't want to design a patient portal without an input from a patient, because that would. Yeah.
Right, everyone. John, a fascinating, interesting 40 minutes contribution from you and all the other people that have spoken. Look forward to having an update. Look forward to future presentations. I mean, Healthwatch, I think, from Worcestershire's point of view, are very keen to be involved and help this to be a success. We're finally seeing some of the details being put to what we were, was indicated 2 years ago at the beginning of the national plan, that IT would be taking a part in this, and we're now seeing that infrastructure starting to be built, and we look forward to future presentations. You're more than willing to stop with us, but if you've got other pressing things to do, and I'm sure you have, please, feel free to leave. But on behalf of everybody this morning, thank you very much for that presentation. It's been really good.
Thank you. Thank you for having me on.
Thank you.
Thank you.
Uh,
Bye now.